We are live, sir.
Good evening, all. Welcome to iFocus Online, the 369th episode, 44th in the Oculoplasty module. Today, we have with us a young teacher and a surgeon par excellence, Dr. Priti Uday from DR Eye Hospital and Agarwal's Eye Hospital, Chennai, to speak to us on orbital fractures. Dr. Priti is a fellowship trained oculoplastic surgeon practicing in Chennai in South India. She has over 15 years of experience in this field. She is currently serving as the medical director, head of the oculoplastics department at the DRR Eye Care and the Oculoplasty Hospital Chennai, and also head of oculoplastics for the Agarwal group of hospitals. She is a global examiner for the FRCS Glasgow and Asia Pacific faculty and the woman ambassador of the AOCMF. She's a well-respected academician and an oculoplastic surgeon, both in her region and abroad, and has trained several oculoplasty fellows and postgraduates. Her special interests are facial aesthetics and orbital surgeries, especially the orbital trauma, virtual planning, and navigation-guided surgery. Over to you, ma'am, for your talk today.
Thank you, Shubha, for the wonderful introduction. Good evening. It's a great pleasure, privilege, and honor to spend this evening with all of you. Thank you very much for this kind invitation to this wonderful platform. My endeavor today is to simplify orbital fractures. I have no financial disclosure. And I would like to say that orbital fractures are always complex injuries, and they have profound functional and aesthetic implications. Usually, it is the young population which is at risk, which is involved, and they have a whole lifetime ahead of them. And post-traumatic deformities and diplopia can be very challenging to live with, very distressing, and they not only cause a psychological impact, but they also cause loss of productive years. And therefore, it is very, very important and imperative for us to understand how these practices.
Can I interrupt? Can you make it slideshare full screen, please?
So it is important for us to understand exactly how these fractures happen and how we need to treat them. Now, non-occupational injuries are 82%, and the sports injuries and road traffic accident form the bulk of it, followed by assault, domestic accidents, and others. And males are more commonly affected. Now, a simple classification for you to remember is that there can be simple or complex fractures. Simple is when a single wall is involved, and complex is when two or more walls are involved. So most often we see a blowout fracture of the floor. So when a single wall, like it can be a floor, it can be medial wall, or it can be roof. These are all simple fractures. Now coming to the zygomatic fractures, these are complex fractures because the zygoma has a very difficult 3D anatomy and it is difficult to reconstruct. These fractures used to be called a tripod fracture, but actually it is a tetrapod fracture. You have 4 fracture lines in this. That is, you have the frontozygomatic, then you have the zygomatico-maxillary, you have the sphenozygomatic, and then the zygomatic arch. So it's a tetrapod fracture. The other complex fracture is NOE fracture. That is when you have the nasal bone fracture, ethmoid bone fracture, as well as inferior orbital rim fracture. There is a classification of that, which you need not know right now. And also the midface fractures, that involves the midface. It can be leaford 1, 2, or 3. Only leaford 2 and 3 involve the orbit. So that is the simple classification that you need to know. Now, coming to some terminologies like blow-in and blow-out fracture. So usually we have blow-out fracture, wherein the orbital wall as well as the orbital contents get displaced out of the orbit. Whereas in a blow-in fracture, the fractured fragment gets displaced inside the orbit. Okay. So now this CT scan, if you see, you have a combination of blow-in and blow-out fracture. The medial wall and the floor is a blow-out fracture, whereas the roof has caved into the orbit, so that is a blow-in fracture. Now, when you have a blow-out fracture, what happens is the bony orbital volume enlarges. So the eyeball gets pushed inside and you get an enophthalmos. Whereas when you have a blow-in fracture, the fractured fragment enters inside the orbit. The soft tissue volume of the orbit increases and therefore you have a proptosis. So here, if you see in this picture, this fragment is inside the orbit. It's a blow-in fracture. Now, there are two theories which have been proposed to explain the mechanism of fracture. The first theory is hydraulic or retropulsion theory, which states that when an object which is larger than the horizontal diameter of the orbit hits against the orbit, the eyeball gets pushed inside. That increases the intraorbital pressure, and the weakest wall, which is the inferior wall, buckles. Okay. But actually, if you follow this theory, you must see, we would have seen more often medial wall fractures, because medial wall is 0.25 millimeter in thickness compared to the floor, which is 0.5 millimeter in thickness. But medial wall has an advantage. It has the ethmoid labyrinth, which gives it some kind of protection to protect itself from the impact of this hydraulic force. And therefore, you see a floor fracture more commonly. And the thinner part of the floor is in the posteromedial aspect, medial to the infraorbital nerve, and that is the area that we commonly see fractures happening. Okay. Now, the other theory is the buckling theory, in which if there is a force to the inferior orbital rim, there is a bone-to-bone transmission of the force, and that causes buckling of the inferior orbital wall, and that causes the fracture. Now, pure fracture is this hydraulic theory, wherein the mid part of the orbit gives way, but the rim is intact. Impure fracture is when the fracture line extends into the orbital rim. So this is what happens. This is a picture taken from the internet just to show you that when you have a floor fracture, the contents of the orbit are going to prolapse. Okay. Now, when there is a large fracture, the contents are just going to be prolapsed. They are not going to be impinged tightly. Okay. And the structure that you see closest to the fracture is the inferior oblique and the inferior rectus muscle. And that is what we see prolapsing most often in a blowout fracture of the floor. Now, the terminology difference between entrapment and herniation. Okay. What is called as the trapdoor injury? You can see this is the trapdoor. What happens is the trapdoor can open and then snap back. Okay. So that's what happens in case of pediatric fractures, where the bone is less rigid. Okay. They are more supple, like green stick injuries, wherein there is a fracture, there is a prolapse of intraorbital contents, and the fractured fragment snaps back to its normal position, impinging some of the tissue that has prolapsed in. So it's a very tight kind of a pinch of tissue like this, which can compromise on the circulation, can cause necrosis, and can cause irreversible damage to the muscle and loss of function. So this is a picture that I've taken from the internet just to explain to you, like the car wheel is in this manhole. It is a prolapse. Okay, so this is not an emergency. You can really wait for the edema, ecchymosis to subside, and then repair this fracture. Whereas when the muscle is going to be entrapped like this in a trapdoor, then definitely you need to repair it early to prevent irreversible loss of function. So trapdoor injuries, when you see a scan, when you see an imaging, the findings are very disproportionate to the clinical findings. All you will see is very little tissue which is prolapsed. You can see here, this is the classical teardrop sign. It's like a teardrop, because it's a very small tissue, but it is tightly impinged, and that has to be released as soon as possible. So this is a child, straight eyes in straight gaze, but elevation and depression is limited. So most of the children who have this kind of trapdoor injuries, the eye is white, and therefore it is called white-eyed blowout fracture. Okay, and this can cause a triggering of the oculocardiac reflex, wherein you have hypotension, bradycardia, and nausea. So the classical picture that we see in clinical practice is it's a child who has had history of trauma. The child goes to a pediatrician. Pediatrician then orders for a CT scan brain because it's a head injury. I mean, they think that it is nausea, vomiting, as well as trauma. So they will only do a CT scan brain, and they will miss a floor fracture. So whenever you see a child with a trauma, with a nausea, you must ask for CT scan of the brain as well as orbit, so that you don't miss this kind of fracture. Because the child will not complain of diplopia. The child will not have any complaints, but when you examine the eye, you will find limitation of ocular movements. Now, these fractures should be repaired within 48 to 72 hours. Now, coming to a presentation of orbital fractures, they can present with decreased vision, periorbital ecchymosis, enophthalmos or exophthalmos. They can be periorbital anesthesia or paresthesia. Now, classically, we say it is infraorbital paresthesia, but that is because the floor fracture is commonest. So the infraorbital nerve passes through the floor of the orbit, and therefore you check the sensation on the cheek, the side of the nose, the upper lip, as well as the gums. But if it is a roof fracture, you need to check the sensation in the supraorbital, supratrochlear areas. Then you can have diplopia, which is a very, very common symptom, very common presentation of a fracture orbit. Now, diplopia need not always say that it is entrapment. Whenever a patient has diplopia, it can be even because of edema of the muscle, edema of the soft tissues. It can be because of nerve involvement. If the apex is involved, third nerve can be involved, you can have a ptosis. It can also be because of a vascular compromise, which is rare. So always any patient diplopia, don't think that they need to be operated. It can be mere edema. Okay. Also, the patient can present with ptosis. Now, ptosis, again, we don't like to repair it immediately unless you see a lacerated levator muscle wherein you want to repair it immediately. If there is just a ptosis, it can be because of edema. So again, you will want to wait for some time for the edema, ecchymosis, everything to subside. It can be nerve involvement. It can be vascular. And late ptosis can also be because of adhesions. So if there is a roof fracture or supraorbital rim fracture, there can be adhesions between the levator muscle as well as the orbital bones. Now, the other presentation, as I said, is nausea, vomiting, or they can also have epistaxis if there is a medial wall fracture. Now, many a times, we as ophthalmologists, we only look at the eye. We forget to ask the patient to open the mouth. That is a very common finding in a fracture patient because this child came to us, normal eye, all the extraocular movements are full, and ophthal examination is normal, but he cannot open the jaw. Now, that is because he has this zygoma fracture. You can see the entire zygoma is pushed inside the maxillary sinus. Now, how does this cause problem with jaw opening? What happens is these fractured fragments of the zygoma, they abut against the coronoid process of the mandible, and that affects the jaw opening. So once you correct the zygoma, the jaw opening gets corrected. So it need not be a TM joint problem. Most of the time, people think it is the temporomandibular joint problem, but it is not a TM joint problem. It can be just the zygoma fracture, the fragments impinging on the coronoid process. So always check for jaw opening in any patient with trauma. Okay. Then rarely you can have orbital apex getting involved, either because of edema or hematoma or a fractured fragment sitting there. That can lead to supraorbital fissure syndrome or an orbital apex syndrome. The distinguishing point between the two is that in a SOF syndrome, you will have third, fourth, sixth cranial nerve involvement along with fifth nerve. So your sensation will be affected, your corneal sensation will be affected, and the pupil will be dilated. But when the optic nerve is involved, it is known as orbital apex syndrome. Now, sometimes the patient can present with CSF rhinorrhea if he has fracture of the cribriform plate. So you can see the CT scan. This is the crista galli, and this is the cribriform plate, which is fractured. In this patient, you will suspect a CSF rhinorrhea. This patient, you should not give steroids. So it's very important for you to understand the anatomy of the fracture because you want to give steroids so that the edema comes down and the diplopia subsides. But if the patient has CSF rhinorrhea, if he has roof fracture or CNS involvement, steroids are contraindicated. Now, management, of course, airway, breathing, circulation takes a priority. After that, you need to rule out any open globe injury or any globe injury per se, intraocular foreign body, corneal protection, and any vision-threatening issues take priority to take precedence over any orbital examination. Of course, medical history is important, past ocular history, because sometimes they have these cataract wounds, they will have a bleb, which can rupture when you're trying to repair the orbit. You have to be careful with these kind of globes. So you need a good past ocular history, current medications, and history of allergies, prior surgeries, tetanus immunization, and last meal. Now coming to complete ophthal examination. Sometimes the eye is so edematous, the orbit is so tight, you are not able to examine, and so you just postpone the eye examination. That is not permitted in any patient of trauma. All your clinics, ophthal clinics, should have this DMAS retractor. You must keep this to retract the eyelid and have a look at the eyeball, no matter how tight the eye is. So this is how you see. This picture is from the internet, and you can see the pupil well. So the two things that you need to do in emergency in any trauma is rule out an open globe injury and check the pupil. So any vision threatening complication you rule out first. Only after that you are going to do the examination of the orbital fracture. Now, sometimes you have this kind of a very severe laceration. Don't jump and try to repair the laceration. You look at the globe, you can see this patient has an open globe injury. Another child, you look at the shape of the eyeball, it is deformed. There is air in the eyeball. There is also a hyperdense foreign body. So all this can be picked up on a good scan. So the eyeball, the scleral laceration has to be repaired first, and only then you're going to think of orbit or the eyelid. So now sometimes the open globe injury can be occult. You can have just the uveal tissue seen through the conjunctiva. These cases need exploration. Open the conjunctiva, check out the sclera. If it is a laceration, repair that first and defer your orbital examination. Another important point that I want to stress today is that whenever you have or you're suspecting an open globe injury, the first thing I see everybody doing is putting an antibiotic drop. Don't do that because these drops are meant for topical use. They're not meant for intracameral use. So some of the preservatives that are used in these drops are not good for the intracameral use. So don't apply any drops or ointment. No further examination should be done. Just do a vision check for medical legal purposes. Don't ask the patient to move the eyeball and you want to check the ocular movements. That's not needed. That will cause further prolapse of intraocular contents. You just put a light patch. If you have this kind of an eye shield, that's the best. And be very gentle, no pressure on the traumatized eye. Now, as I said before, after you rule out an open globe injury, check the pupil. Your second job is to check the pupil. Now, whenever you have a very tight orbit like this, and when the pupil is affected, the first thing that you should do is release the orbital pressure. You don't have to know what is the cause of increased orbital pressure at that moment. So don't send the patient for CT scan. You'll be just wasting time and the optic nerve injury can be irreversible. So when you have RAPD and you have increase in the intraorbital pressure, just do a canthotomy and cantholysis, which can be done even in the ward. Okay. Now this increase in the intraorbital pressure can be because of retrobulbar hemorrhage. You can have a keratoconus fistula, or you can have an emphysema like this. Okay. Whatever the cause is, your treatment will be initially canthotomy, cantholysis. So what you need to do is, I'm putting a hemostat here to achieve hemostasis first. It is a very vascular area. And then you just have to cut the lateral canthal tendon first, and then the inferior limb of the lateral canthal tendon. Still, if the pressure is not released, you can also cut the superior limb of the lateral canthal tendon. Once the pressure is released, only then you will send the patient for scan to find out what the cause is of the increase in the intraorbital pressure. Okay, so that's how you do a canthotomy, cantholysis. Everybody should know to do this. You can do it anywhere. And if it bleeds also, just a pressure is enough to stop that bleeding. And don't close this canthotomy, leave it open. Okay. Now, when the orbital pressure is not high, but still you are having an RAPD, there is no intraocular trauma, then you think of optic nerve involvement, that is traumatic optic neuropathy, which can be direct or indirect. If you are having a bone fragment impinging on the optic nerve, that has to be cleared surgically as soon as possible. If it is just a contusion injury and there is no contraindication for steroid, that is a controversial topic, but most of us like to start with IV methylprednisolone. Now, sometimes you can have a patient like this with just congestion, history of trauma, dilated superior ophthalmic vein. That tells you that it can be a CCF. Another patient like this, which is more dramatic, it can be a direct CCF, or less dramatic like this, again, dilated SOV, it can be a indirect CCF. So trauma can cause all kind of CCF. You must remember to rule that out when you examine the patient. Now, once you have ruled out the pupil is normal, vision-threatening complications are not there, then you go on to examining the patient. You measure the proptosis or enophthalmos. Now, if your lateral orbital rim is intact, you can use a Hertel's exophthalmometer to check the proptosis or enophthalmos. But if your rim is not intact, a Hertel's is not going to give you a perfect reading. And you can use two perspex rulers to measure how much the globe is displaced inferiorly or anteroposteriorly. And also you feel for crepitus, check for periorbital sensation. If the rim is involved, you will get a step of deformity. Check the ocular movements. Superior sulcus deformity tells you that there is an enophthalmos. NOE fracture, naso-orbitoethmoid fractures, can lead to telecanthus, so you need to check the intercanthal distance. Always do a syringing in all trauma patients, even if it is not an NOE fracture. Sometimes the fracture line can extend in the mid-NLD. There can be edema of the nasolacrimal duct system. So you need to do a syringing in all patients of orbital trauma. If there is a ptosis, examination of ptosis is important, and Brui, of course, to rule out any CCF. Now, visual field should be examined if you suspect optic nerve injury, and diplopia and Hess chart. Now, Hess charting is very rarely done now, but yes, diplopia charting we like to do. Now, force duction test is another test which they ask you in exams, but very rarely we do that in the clinics because we have the imaging now, and more or less the imaging gives you a very confirmatory diagnosis. Only if you are confused between whether there is an entrapment or there is a neurological involvement, an FDT will help. But you must remember that FDT can trigger an oculocardiac reflex, and therefore you must have an emergency kit next to you when you're doing an FDT in the clinic. Also, try to anesthetize the area where you're going to hold at the limbus with a cotton-tipped applicator dipped in lignocaine. Hold the conjunctiva and the tenons together, otherwise you will tear the conjunctiva. And then you move the eyeball. So here you can see there is restriction of inferior rectus. The rest of the movements are all normal. So this is a positive FDT for entrapment of the inferior rectus muscle. Now, coming to radiological investigations, X-rays are not routinely advised nowadays. But in case you need to ask for an X-ray, you ask for a Waters view, because the chin is elevated so that the image of the petrous bone goes below the maxillary sinus, and that helps you evaluate the floor, the maxillary sinus, as well as air fluid level in the sinuses. And you can also see air in the orbit or emphysema. The investigation of choice in these patients is a CT scan, because a CT scan, you can nicely see the extent of the fracture. You can also see the soft tissue, the muscle entrapment, also intracranial hemorrhage, etc. can be picked up on a CT scan very well. And you can also use the CT scan in your navigation platforms and do mirroring and also try to symmetrize both the sides of the orbit. So now when you order for a CT scan in a trauma patient, ask for thinner cuts. Normally they do about 3 to 4 millimeter cuts, but we want thinner cuts, that is 1 to 2 millimeter in thickness. In fact, nowadays we are getting 0.6 millimeter cut thickness. And you also ask for coronal, axial, sagittal, as well as a 3D reconstruction, so that you can see all the walls of the orbit comfortably. If you want to see the roof and the floor of the orbit, a good section would be coronal sections. Now, the medial wall fractures are better seen on an axial section, and sagittal gives you a very nice view of how the implant is sitting on the posterior ledge, how long is the fracture. So a sag view is very, very important view for a floor fracture. And of course, a 3D reconstruction to get a 3D orientation of the anatomy of the fracture. And also you should have a bone window as well as soft tissue window. Like in this case, a soft tissue window will tell you that inferior rectus here is prolapsed inside the floor fracture. Also, these CT scans can be sent for 3D printing, and you can get a 3D printed skull models like this. We get these models for most of our patients now, so that you can plan your surgery on these models. Like this patient has a bony callus, I've removed it virtually. And then I've also pre-contoured implants on this. Also, if you want to achieve symmetry between the two sides, you can have a mirrored skull model. So you mirror the normal side on the abnormal side and get a 3D printed skull model and pre-contour the implants on that model. Then autoclave these implants and use it intraoperatively. That ensures that your reconstruction is more accurate and symmetrical. Now, MRI is rarely needed in trauma patients except when you are suspecting optic nerve or CNS pathology, or you're suspecting a wooden foreign body. Because wood is like an air shadow on a CT scan, and sometimes you can get confused. So MRI is a good option for wooden foreign body. Now, this was a case who came to us with a very large wooden foreign body. This was picked up on CT scan because it had some paint on the outer side, which was hyperdense. Otherwise, it would look like this, like an air shadow. And this was a 8 centimeter long foreign body extending from the orbit into the intracranially. And it was a 1 week old injury. So there was necrosis of the lower eyelid as well as the sclera. You can see the pus coming out when we have removed the foreign body. And then we have reconstructed the lower eyelid and given him a prosthetic eye. Now, coming to management, whenever you see orbital fracture patient, you advise ice compresses, give them antibiotics, analgesics, anti-inflammatories, oral steroid if there is no CNS involvement, roof fracture, cribriform plate fracture, no other contraindications for steroids. Nasal decongestants are helpful if there is a middle wall fracture. The most important instruction that you need to give these patients is do not blow the nose. That is because if they blow the nose, the air from the sinuses will enter inside the orbit. And if the volume is high, that can compromise on the optic nerve. Now, coming to surgical indications. Now, whenever you have a fracture which is causing enophthalmos of more than 2 millimeter, or it is causing diplopia and functional gaze. Now, that is very important. Most of the time, most of us have straight gaze and down gaze as our functional gazes. But there can be some occupations like librarians who need the superior field of vision. Those patients, you will repair the fracture even if there is diplopia and up gaze. So it depends on what is their functional gaze. Also, fracture involving more than 50% of the floor. So if it's a very large fracture, even if the patient has no diplopia, you want to correct it to prevent future enophthalmos. Because now in the acute setting, the patient will have edema. You will not know enough. You will not be able to appreciate an enophthalmos. But with time, these patients go in for enophthalmos. And therefore, to prevent that, if it's a large fracture, you must repair it. Also, of course, if it's a trapdoor fracture or if there is a significant hypoglobus or there is difficulty in mouth opening, you're going to repair these fractures. So there are only very few situations where you're going to observe. That is when you have a non-displaced fracture with no motility disturbance, you can observe these patients. When the general condition is poor or when there is a globe perforation or if there is a severe ocular trauma like a retinal detachment or a hyphema, you're going to observe these patients. Or if there is now important criteria, one more important point for observation would be significant orbital fracture of the only seeing eye. So if the patient is one-eyed and if that seeing eye itself has got a very severe orbital trauma, we like to defer surgery. So some situations I will show you now. This patient had diplopia in upgaze, limitation of upgaze. But you can see that the fracture is very small in the posterior orbit involving the floor and the medial wall, but there is no entrapment. So you don't need surgery in this patient. I just put him on steroid and his ocular movements recovered. It can be just edema of the extraocular muscles. So diplopia does not mean surgery. Another patient, you can see the entire floor is down. It's a large fracture. He came to us after 2 months. You see, he has enophthalmos. So in the acute setting, you may not see it, but later you will see it. So these large fractures need repair. So this was another large fracture. We have repaired it. Now, another patient who has diplopia and upgaze, he needs the upgaze, so we have repaired it. There is hypoglobus. There is a fracture of the roof. You can see the fractured fragment is displaced inside the orbit. There's also intracranial hemorrhage. So we have done this case with a neurosurgeon. Bicoronal incision was taken. A burr was created near the fractured fragment so that you can lift the depressed fragments. And also we have done our upper lid crease approach so that we can release the fractured fragment from the orbit and then use a titanium mesh to keep the pieces in place. And you can see the fracture is very well repaired here. And post-operatively, the patient's hypoglobus gets corrected and also his ocular movements are full and diplopia gets corrected. Similar patient, another elevation limited. You can see fractured fragment, which is abutting the superior rectus muscle. We release that fragment and the elevation has improved and diplopia settles. So another patient who came to us with ptosis, but what we noticed is that he has slight amount of hypoglobus. So the eyelid always follows the eyeball. So whenever there is a hypoglobus, the patient will have a ptosis. You need to correct the hypoglobus and that corrects your ptosis. You can see elevation also limited. On inquiry, he gave us history of trauma. And when we did a scan, we saw superior roof fracture with a fractured fragment inside the orbit. Similar procedure we have done for him. And post-operatively, his hypoglobus gets corrected and the ptosis gets corrected. So that's a pseudo-ptosis and you need to only correct the hypoglobus. So this was the pre and the post-op. Another patient, left eye, pseudo-ptosis. he has a fracture, repair the fracture alone, ptosis gets corrected. Another patient, she has enophthalmos that is causing the ptosis. Again, pseudotosis because of enophthalmos, correct the fracture and that corrects the ptosis. So very often post-traumatic patients come to you for ptosis repair, rule out a hypoglobus, enophthalmos, and only then think of ptosis correction. That patient which I showed you, the jaw opening was affected. We have repaired it with a conjunctival approach and a vestibular approach and fixed his zygoma in two places. You can see frontozygomatic and the zygomatic maxillary fixation, and his jaw opening improves. Another patient, very comminuted zygoma fracture, again repaired so that her horizontal width of the face also gets corrected and the facial deformity gets corrected. Now, coming to timing of the surgery, usually we like to wait for a week or 10 days. So fracture repair is never an emergency. You have to wait for the edema and the ecchymosis to subside so that it is much easier for you to dissect, retract the globe and see the fracture and repair it. But at the same time, the fibrosis is not set in, the bones are not fused, and it is easier for you to reduce the fracture. But trapdoor injuries, you will operate much earlier. Now, coming to approaches, you can have a transcutaneous and transconjunctival approach. We, as oculoplastic surgeons, have completely moved to transconjunctival approach. We have no external scars in these patients. And we also access through the vestibular approach. So when you have a zygoma fracture, you access the fracture from the inferior conjunctival approach as well as from the vestibular approach. In that way, you will have the entire zygoma exposed and you can repair the fracture well. But for the sake of exams, the transcutaneous approaches, you can have sub-brow approach, you can have the Lynch approach in the medial orbit. The superior lid crease approach is a very good approach for the upper, for the roof. You can have infraciliary approach, which is again a good approach. The lower lid crease as well as inferior orbital margin approach is no longer used now because it causes a lot of lymphedema. It affects your lymphatics in the eyelid and it can cause eyelid problems like eyelid retraction, ectropion, as well as a chronic edema. So these two incisions are virtually not used now. If you want to do a transcutaneous approach, the approach would be a lateral canthotomy and then you do a subciliary incision or you can do a lid crease incision. So this is how a subciliary incision looks like, and you can then dissect up to the inferior orbital rim and then open the septum and enter the orbit. Now, conjunctival approach is the commonest that we are using. We do a canthotomy, cantholysis, and then an inferior fornix approach that is called the swinging eyelid approach. And that can extend medially through a transcaruncular approach. So virtually your medial wall, floor, and lateral wall can be exposed in that way with no external scars. And of course, when you have a frontal bone fracture or a roof fracture, you need a bicoronal approach. Also, if you have a zygomatic arch involvement, then you need a bicoronal approach. So this is how the conjunctival approach looks like. This is the fracture, which is nicely dissected and seen well. So you get a very good exposure by a conjunctival approach. Another is vestibular, what I was talking about. This whole area of zygoma can get exposed if you go through a vestibular approach. You can fix the maxillary buttress through this approach very comfortably. Also, you can fix the piriform aperture of the NOE fractures comfortably through this approach. So you go from below upwards and from upwards down so that the entire zygomatic bone is exposed. Now, coming to the choice of implants, you can have autogenous or alloplastic implants. We mostly use alloplastic implants, but autogenous implants like bone and cartilage can also be used. Now, the alloplastic implants can be porous polyethylene, titanium, silastic methyl methacrylate, and we also have bioresorbable implants and the PEEK implants. The most popular one for the orbit is titanium implants. That is like this. Now, these kind of pre-contoured implants are what is preferable because the orbital wall is not a straight wall. The orbit has got some curvature. It has got a convexity posteriorly along the floor. So that is known as the hammer's key area. Also, there is a convexity posteriorly along the medial wall. And these convexities should be recreated when you repair the fracture so that your enophthalmos gets corrected well. You can see from this implant how much curvature the orbit has. And this is very difficult to recreate manually. So that's why when you have this kind of bone grafts, it's very difficult to get this kind of a contour. So and these implants are very stable. So very bad fractures which require a lot of stability, titanium implant is preferable. And they're radio opaque, they're nicely seen on scans. And it's a mesh structure, so therefore there cannot be any compartment syndrome. It allows egress of fluid from the orbit, and there is no donor site morbidity. However, they are expensive. They can sometimes have sharp edges and tissue ingrowth. Now, bone graft, as I said, they have low cost. And they have maximum biocompatibility because you're taking the patient's own tissue, but you cannot carve it the way you want. So contouring is difficult. And also donor site morbidity is there. And also resorption is very unpredictable. Okay. So bone grafts are virtually not used much in today's practice. Now, another popular implant is porous polyethylene sheets. Now, these you can cut them as you want. You can also thin them down. You can pass sutures through them. You can bend them. And also these are available in various shapes. You can augment your rim. You can do all kind of things with these Medport or porous polyethylene sheets. They also come with a barrier film. So one side is smooth compared to the other side. So the smooth side can be kept on the orbital side so that the muscle can glide nicely over the surface. And these are porous, so it causes ingrowth of the orbital tissue and they get integrated within the orbital tissue. But you can see that the sheet is so thin and they are so flexible, so they can't give you much of stability. So if you have a small fracture, you have a stable bone on all the three sides, then this implant is very useful. But if you have a very complex fracture involving 2 or 3 walls, then you need a titanium. And these are not radio opaque and they cause less drainage from the orbit. So sometimes, the edema can get compartmentalized. Now we have composite implants, like you have Medport coating of the titanium implants. And as I said, bioresorbable implants, they get resorbed with time and replaced by bone. So these are again very useful for pediatric age group. Again, they are not very stable. They are thin sheets, and therefore you can use them in very small fractures, like in pediatric patients who have trapdoor fractures. They don't need much stability, and for them, these implants are quite nice. And now we use a lot of PEEK implant for the rim reconstruction. So when you have secondary reconstructions, you want to augment the rim, we use this PEEK material, which is polyether ether ketone. Now, the principle of repair is we always repair the rim first and then the wall. So if you have a rim involvement along with a floor fracture, you will do the rim first and then put the mesh for the wall. And when you have many bones involved on the face, you will follow a pattern. Either you go from up to down or you go from outside inwards and repair one by one each bone. So what we do is we try to reconstruct the buttresses of the face. So buttresses are like pillars of any building. So you have horizontal buttresses and vertical buttresses on the face. So horizontal buttresses is this frontal bar, that is a supraorbital rim. You have the inferior orbital rim and you have the hard palate. So all this should be reconstructed well. And then you have the vertical buttresses, that is the nasomaxillary, the zygomaticomaxillary, and the pterygomaxillary. All these buttresses, once they are repaired, the fracture becomes stable. And as I said, there is the floor is not a straight wall. It has got a convexity posteriorly, and that is what pushes the eyeball forward. So that has to be reconstructed well for you to correct the enophthalmos. That is called the Hammer's key area. And also this junction between the floor and the medial wall, that is the transition zone, should be correct for you to get the convexity in the right place and for you to correct the enophthalmos well. So these are the two important points that you must remember. Also, the implant should always sit or rest on a stable bone posterior to the fracture. So if this is the fracture from here to here, you can see that there is a stable bone posteriorly. The implant should rest on that bone, which is called the posterior ledge. You have to dissect till there. Otherwise, the implant is going to be like this. It will be falling inside the maxillary sinus and it won't be stable. And then depending on which area of the, which bone is fractured, you can use that shape of a plate to reconstruct. So it just looks very complicated, but it's actually very simple. When you are doing the rims, you are going to use C plates. And when you're going to do the lower part of the zygoma, you will use the L or the Z shaped plates. So depending on the area, so you can see here along the rim, you have C plates. And along the side of the nose, again, you need a curved plate. So it is a C plate. So these various shapes are available depending on the area you are going to repair. So this is a small video. You do the FDT first in any trauma patient, post-duction test. Then you do a canthotomy cantholysis, and inferior fornix approach is used most of the time to, now this is a patient with a floor fracture. And then you can go either preceptally or postseptally up to the inferior orbital rim, and then incise the periosteum at the inferior orbital rim and elevate the periosteum. Then you will see the fracture. You reduce the prolapsed contents of the orbit by a bimanual approach. So you have to be very careful in releasing the contents. If there is a tight impingement, you can use a Keresens to enlarge that fracture and release it atraumatically. So you can see the anterior part which is moving, that is the fractured fragment. That is the infraorbital nerve here. This whole big thing is the infraorbital nerve. And now I'm going to place the titanium implant and then fix it at the inferior orbital rim with a screw. And since I don't need these prongs to fix, I'm just cutting off the prongs. And then again, you repeat the FDT, making sure that there is no tissue impingement. And then just close the conjunctiva at the fornix as well as close the lateral canthotomy. So you can do a complete huge fracture repair with no external scars. And this is the canthotomy being closed and the eye looks perfectly okay. During surgery, you need to check the pupil at all time for you to rule out any optic nerve injury. So this is how the repair is done. Now, what is unique to the kids? In the kids, you will see that they have a larger neurocranium compared to a facial skeleton is smaller. So you can see the proportion of the skull to the face. And as they grow into adulthood, you will see that this proportion becomes more equalized. So since the child has a larger neurocranium and their sinuses are also not pneumatized, we see more of roof fractures in pediatric age group compared to adults. So roof fractures are most common between 2 to 6 years of age. Floor fractures are more common after 7 years after the maxillary sinus develops. Entrapment is more common in children. And also we must look for signs of child abuse, and there is also risk of amblyopia. Now, when there is a trapdoor fracture in a child, the best implant to use will be resorbable implant or porous polyethylene implant. If it's a complex large fracture, you need to use titanium. But there is always a controversy to use titanium because it's a rigid fixation. So it will affect the growth at the suture lines. And therefore, up to 5 years of age, we are a little skeptical in using titanium implants. After 5 years of age, you can use them. So there is concern regarding growth retardation and asymmetry, or also displacement. The screws getting loose, migration with skeletal growth is possible. And therefore, after up to 5 years of age, you have to think twice before using a rigid fixation. Now, this was a child, again, he had elevation limitation, a trapdoor fracture. This was the fracture that is seen on conjunctival approach, and post-surgery, his movement have recovered. Another patient, he has a fracture of the rim, superolateral rim, which is now touching the eyeball and causing a hypoglobus. We have again repaired it with titanium. And you can see this plate. So it's along the rim. So you use a C plate and repair it. And this is the post-surgery. So children are not small adults. Their entire profile of injury, the type of injury mechanism, and the use of implants are all different compared to the adults. Now, once you have repaired the fracture, usually we give a propped up position to the patient. We ask them to apply ice packs. A close monitoring of the vision and pupil is required. And we must avoid nose blowing. That is very, very important. The other complications are optic nerve compression, residual diplopia, under or overcorrection of ophthalmos or hypoglobus. Any infection, fistula formation can happen. Lower eyelid malpositions are very common now since we are doing conjunctival approach. If it's not done well, we see lid retractions, entropions, and if it is a transcutaneous approach, ectropions are common. Also, infraorbital nerve dysfunction and displacement of implants are other complications. Just 2 minutes on recent advances, that is navigation guidance, virtual planning, and 3D printing. So navigation guided surgeries like the GPRS in the car, you get real-time guidance during surgery. So you have a navigation pointer in your hand, and wherever you point, wherever you keep the tip of the pointer, you will see that on the preoperative CT scan of the patient. So what we do is we upload the preoperative CT scan on the navigation platform. We plan the whole surgery virtually 1 day prior to the surgery. You can even place the implant that you're going to use virtually and see if it fits well. This is how navigation is. So here I'm touching the lateral canthal area, and you can see that bone on the coronal axial as well as sagittal views on the navigation. So in very severe trauma, complex fractures where the entire anatomy is distorted, and when there is secondary reconstruction, navigation is very useful. Here I have now placed the implant, and you can verify if the implant is in position or not by using navigation. That's what I'm doing here. I'm running the navigation probe over the implant and seeing whether it is in place. So this is the setup, how navigation looks like. It takes about 15-20 minutes extra to set up the navigation. And then you do the surgery normally. And whenever you're in doubt, you use the navigation probe. So these are some of the patients. Like this patient had a ptosis. You can see that there is a laceration here. He has a telecanthus. He has a floor and medial wall fracture. This is his 3D printed skull model. We have used navigation so that we have symmetry in the two sides. You can see this is the implant here. And then we have also done the ptosis repair and the telecanthus repair, and that is the post-op result. Another patient, he has been operated by a facial-max surgeon, but he has residual enophthalmos. You can see he has left behind the floor, and also the zygoma is rotated. It is not repaired correctly. We have used navigation. You can see this eye tracker, and we have redone the surgery. Here it is a tetrapod fracture, therefore we need to do the arch also. So I'm using a preauricular incision for the arch, and this was the post-op result. Now another patient, very severe enophthalmos, we can use this navigation platform to customize implants for the patient. So if you have a very large fracture where the ready-made implant will not fit, we have customized an implant for him, and that's what we have used, and you can see enophthalmos gets corrected very well. He needs some soft tissue repair, which should be done as a secondary procedure. Another patient who has got a prosthetic eye, he has again got a very malunited zygoma fracture. We have used a customized implant for him, reconstructed the bony framework first, and the soft tissue only drapes the bone, and then you do the ptosis repair and the lid reconstruction, and then you get the appropriate cosmetic result. So this was all for today. Whenever you have an orbital fracture, you must remember that secondary reconstructions are extremely difficult, and therefore you should do it right the first time. You never get a second chance. Thank you very much for this lovely invitation and your kind hearing.
Thank you so much, ma'am, for such a lucid lecture and extensive coverage of the topic on orbital fractures. We do have a few questions from the various social media portals, ma'am. With your kind permission, can we proceed with a few of them?
Yes, please.
Okay. Ma'am, in a case of orbital fracture, undisplaced at the primary visit and later left alone, 3 months later presents to us, is there a role of oral steroids in such a case?
No. But why would you want to use the steroid? What is the problem now after 3 months?
Probably the viewer wanted to ask if there is any persistent diplopia or what, probably, but the edema usually settles down in the first one. Yeah.
Steroids are not indicated, but depends on what the patient complains of after 3 months. If there is diplopia, it cannot be because of edema or inflammation. So steroid is not going to help in that case. You would have missed an entrapment or missed a small tethering of fibers on the fractured fragment. So in these cases, dynamic MRI is very good. If you have just few fibers entrapped, you feel everything is okay, so that you can make the patient look up and down during the MRI. And a dynamic MRI gives you a very good view of the fractured fragment as well as the muscle movement. And that is a useful thing, or you can do an FDTNC.
What is the concept of inferomedial strut in a case of orbital fracture repair?
So that is what I was saying. The transition zone between the floor and the medial wall is the inferomedial strut. So that gives you, if that strut is intact, your reconstruction becomes very easy. You're going to place your transition zone just at the strut and you will get the reconstruction correctly. But if your inferomedial strut is not there, then it is extremely difficult. You can place the junction either little laterally, little medially, and go wrong completely in your reconstruction. So in these cases, navigation is useful when you have a very large fracture with no strut in between. Or you can now also pre-contour your implant on the skull models and have a drill guide. So now what we do is, if you don't have navigation, you can sit with the company which makes the customized implants, ask them to make you a guide which is not expensive at all. So it gives you the exact location where you must drill. And once your drill holes are in correct position, your implant will be in correct position.
Ma'am, how do we cater to the size of the implant to be put in a orbital floor fracture repair?
So as I said, you must dissect up to the posterior edge. Most of the time, unless your fracture is very, very severe, your palatine bone is intact. That is your guideline. Your implant has to sit on that and not to go more posterior, but let it rest on that posterior edge. Then your reconstruction is usually very comfortably adequate. But if you don't have a posterior edge, then you need again some kind of a pre-op planning, like you do it either on a 3D printed skull model or you use intraoperative guidance, because you won't know what is the exact position of your posterior end. It can go down, it can go up anywhere if you don't have a posterior edge. So I think there is no one size fits all. In your intraoperatively, you have to see where you have the stable bone, rest your implant on that, then you will be fine. And make sure that there is no rim fracture. Many a times we see the surgeons just putting in a floor implant, but the rim itself is down. So the entire reconstruction goes wrong then.
Ma'am, in a case of a pediatric age group, say a 5-year-old child with a history of a fall, has a polytrauma, after having stabilized the baby, making sure that the ABC is taken care of and secondary repair is being planned. And if the child actually on the CT evaluation shows bilateral orbital fractures, how do we proceed with such a case? What should be our preoperative planning?
So if it is bilateral fracture, depends on what kind of fracture it is again. And 5-year-old again is a very transition age between rigid implant and non-rigid. The fact that it is a bilateral trauma means it's a very severe trauma. Probably your zygoma and everything will be affected, which is very rare unless it's a very, very severe injury. So, but in those cases, we have to use a rigid implant. Taking care, telling the parents that you may need to remove the implant later if the bone growth is affected. So implant removal also is indicated. Sometimes you can have migration of screws because the bone is growing. So you can have bone ingrowth also on the implant. So all these are explained to the patient. You make a plan either from up to down or outside to inwards. So that is how we repair a polytrauma on the face. But you can't do much of virtual planning if it is bilateral. Your navigation and all does not work much when there is a bilateral trauma.
Ma'am, in cases of like one of the examples of the case which you just showed in the presentation where a primary repair was done by a maxillofacial surgeon and then the zygoma was interned and not repaired correctly. How do we convince the patient for the second surgery? And in cases of resurgery, what are the steps to be taken? What are the pointers to be kept in mind while operating?
So when you have a zygoma fracture, you must first see whether there is any callus formation or there is a so callus formation is the most important thing, because what happens is when there is callus in the growing fragment, then there is a gap between the two. So if you're going to re-osteotomize that fragment and put it back, you won't know exactly where to put it because there are gaps, correct? So a secondary repair, always you must make sure that you have some kind of a bony landmark for you to place the fractured fragment correctly this time. So when you repeat a surgery, always you must have that in mind. If you have your bony landmarks in position, then you can re-osteotomize that and place it back in normal position. What I find is 90% of the times when the facial max surgeons do it, the floor fracture is left behind. So many a times, if you just do the floor, most of the volume correction gets done. But if you feel that the zygoma is rotated too much, then you can re-osteotomize and redo it. But if you have a bony callus, you have no bony landmarks, then an onlay implant, which is customized, is the best. That is, you do an onlay peak implant, something to augment whatever is deficit, instead of moving the whole bone again. And we tell the patient that primary repair was done because the trauma is so severe. Always in these cases, you need multiple surgeries. So you need some more augmentation this time. That's what we tell the patient. Explain to them on a 3D model and as well as on a CT scan, whatever we are doing, because it's a large procedure. You need to remove these implants, put it back. You have to explain to the patient everything.
In a case of a well-repaired fracture presenting to us with enophthalmos, what are the possible ways to augment the volume and symmetrize both the eyes?
This is so difficult. That what I always feel is that the bony reconstruction is not done well. I always tell everybody the same thing because the convexities are not followed. So many a times or most of the times I redo the bone work again because that's the best way to cure the enophthalmos. Because an enophthalmos which is visible to you is more than 2 millimeter enophthalmos. That cannot be because of a fat resorption alone. Usually fat resorption usually causes 2 millimeter or less enophthalmos. So obvious enophthalmos I feel is always because bony work is not done well. I augment the bony work in some way. Either I put a peak. Nowadays I use peak very often for the rims, and the mesh has to be redone and placed in the correct position.
Ma'am, in cases of post-traumatic orbital fractures, where there is a periocular cicatrix, and the plan is to use 5-fluorouracil to basically for scar modulation, let us say, what should be the timing of that periocular cicatrix management and repair of orbital fractures?
Ideal time for 5FU is 3 weeks to 3 months. But I feel that it is useful even for late fractures. It softens the scar even up to a year. So, but earlier than 3 weeks is not going to help because fibrosis doesn't even kick in by then. So 3 weeks to 3 months is the ideal time. Whenever I do a redo, like if I'm doing a secondary reconstruction, I expect more scarring. I tell them we are going to need injections. And I tell them that they will have to come on review itself. I start injections prophylactically for all these patients. Very young patients also, sometimes you can see them scarring a lot. You start them on 5FU. I don't use much of Tricot or Kenalog because it depigments the skin. I prefer a 5FU.
I mean, how many sessions of 5FU do you prefer, ma'am, in such cases where the scar modulation
Depends on the response. If I see that he's responding, I would keep going. But if I feel that there is no response after 2 injections, I won't give anymore.
Thank you so much, ma'am. That's all the questions we have for tonight. If any of the postgraduates who have logged in want to ask any question to Dr. Priti, she'll be more than happy to answer. We have Dr. Prasad and Dr. M. Ravi Kumar and all the other people who have joined in for this beautiful session by ma'am. I guess that's it for tonight, ma'am. Before we conclude, I have a small announcement to make. We meet next on the 10th of January. The topic being peripheral nerve and optic nerve, meningeal and neuroectodermal tumors by Dr. Sachin Salvi. See you all there.
See you. Bye-bye. Thank you.
Bye. Good night.
Good night.